The following podcast is part of a certified educational activity titled Breaking Through Biases in Obesity Management, Building Competence, Creating Connections, and Empowering Leaders in Primary Care. Access the entire activity and complete the post-test at peerview.com/ZCB860. Downloadable slides and practice aids are also available.
Welcome to Breaking Through Biases in Obesity Management, Building Competence, Creating Connections, and Empowering Leaders in Primary Care. I'm your host, Angela Fitch, co-founder and chief medical officer of KnownWell in Boston, Massachusetts, and past president of the Obesity Medicine Association. Joining me today are my colleagues, Dr. Jamie Almondos from the University of Texas Southwestern Medical Center in Dallas, Texas, where he is the medical director of the Weight Wellness Program and an associate professor of internal medicine in the Division of Endocrinology and Metabolism.
Thanks for having me, Angela.
Thanks for being here. And Dr. Carolyn Francavilla-Brown is an assistant professor at Rocky Vista University in Lakewood, Colorado, and is the owner of Green Mountain Partners for Health, the founder of Help Your Patients Lose Weight, as well as GLP Strong, and the creator of the Dr. Francavilla Show on social media.
Thanks for having me as well.
Thanks for coming. We're delighted that you have joined us for this dynamic and wide-ranging dialogue, which is designed to help you refine your understanding of obesity as a chronic disease and equip you with strategies for using shared decision-making to develop effective, realistic, long-term obesity management plans. Now let's dive right into it and talk about obesity as a chronic disease. The WHO defines obesity as an abnormal or excessive fat accumulation that presents a risk to health. I like this the best because it's kind of the shortest there, but again, the idea is it's more than BMI, right? It's more than a number on a scale. It always has been. You have the CDC here and the OMA, which also have guidelines in which we talk about the diagnosis of obesity as more than just weight, as how is that excess adiposity, that excess body fat also affecting our health. Now, recently, the Lancet Commission took that a little bit of a step further in terms of taking that information and saying, hey, if you have excess adiposity, right, not just a high BMI, but in addition to BMI, you maybe have a larger waist circumference or you actually have measured a patient's adiposity. And if they have that excess adiposity, then they have obesity, right, in addition to the elevation of the BMI or the weight. And then they take it one step further to say that if you have preclinical obesity, that is where maybe that obesity isn't affecting your health yet. So there aren't any true direct health consequences at the moment, right? And the idea being that preclinical obesity might be a state in which we can, take things a little bit slower, potentially. And maybe not, right? Again, maybe we'll find in the future that treating preclinical obesity is intensively is what we should be doing, right?
Sounds like a great thing for prevention, right?
Exactly, right? So really sort of, delving into this a little bit further. The pathophysiology of clinical obesity is complicated. We're going to get into that in a little bit. But the idea is we have this excess adiposity that then is leading to abnormal pathophysiology in our bodies, systemic pathophysiology, effects on our inflammation, lipotoxicity, mechanical stress even. And then organ pathophysiology, right? Dysfunction in our kidneys, dysfunction in other organs, cardiovascular dysfunction, et cetera. We have the Edmonton Obesity Staging System. We've had this for quite some time, which also takes that a little bit of a step further and says, we have obesity, but if we also qualify that into stages, stage 1, stage 2, stage 3, meaning that the disease is more severe or affecting the human body a little bit more, much like we have also with cancer, right? We have stages in cancer, and that dictates our treatment and also potentially the patient's outcome, right? Predicts, how severe their disease is. So how in clinical practice, Dr. Francavilla, do you use these sort of tools to guide your patients?
Yeah, well, I'm in a family medicine clinic where I focus on weight. And I think ultimately we're really having a shared discussion with the patient about what are their concerns about their weight, what are our concerns about the weight, and what are medical conditions that they have currently related to their weight or that they might have related to their weight, right? What risk factors are we seeing and how is it impacting their life? So getting a little bit of the history, looking at the medical history, the patient's personal history to really figure out how weight may be impacting their health or might be likely to impact their health in the future.
Dr. Almondos.
I treat obesity at an academic medical center where people are referred to an obesity medicine program to treat often severe complications and comorbidities associated with their obesity. And so helping people to understand the relationship between the excess adiposity and their health, but also having conversations around what their goals are can really help people to formulate kind of an idea about where they're going as a team with us on their obesity care journey.
So important. And we're going to talk about that further right now. So what are some barriers, though, to developing or to delivering this obesity care? So barriers exist at multiple levels. The Action.io study was the largest international survey of perceptions, behaviors, and barriers for effective obesity care that's ever been performed. And so it identified some gaps in care. So there's a delay in approach. It took 6 years, which was the mean, for people with obesity to discuss weight with their healthcare providers. I think we see this all the time. Patients say, I've done this my entire life, right? One of my patients is 75 years old, and she says, I've been doing this for 50 years, right? So they're really more experts sometimes than we are in terms of their disease state. 68% of people with obesity expected healthcare providers to initiate the weight discussions. When that's what we're going to talk about in a bit, is how do we initiate those discussions?
Yeah, that statistic really surprised me because I think what I'm hearing from my colleagues is that more patients are coming to them now to discuss weight. But I think it's really important we remember that, patients really are still expecting us to drive this discussion in most cases.
So important.
Yeah, and it's so different. We wouldn't wait 6 years to discuss somebody's elevated blood pressure, right?
Right. Exactly. But because of that bias and stigma, which we'll talk about in a second, right, is really something that is important to understand. Because healthcare providers had this in the Action.io study, showed low motivation, felt that patients showed low motivation in terms of a barrier to weight loss, right? That the healthcare providers felt that people with obesity were not motivated to lose weight. And that's part of this bias, right, that we have that we'll share, and we'll talk about how to overcome. And one of the issues with that is there's a lack of training in healthy weight and obesity care, as far as patient-centered conversations, which is why we're here. Lack of training in evidence-based obesity care itself, in pharmacotherapy, and how do we have lots of training in how to treat blood pressure, during medical school, but not so much as it relates to obesity care. In a recent survey, in approximately 30% of the 141 U.S. medical schools surveyed, there was little or no education in nutrition and behavioral obesity interventions. And I don't know if that's how you felt back when you were in medical school. Or...
I certainly felt like I had to seek it out. And I was actually at one of the schools with one of, the nation's leading experts of this at the time. So I certainly had to seek it out to feel like I had that additional training to feel confident in this.
And hopefully it's changing now as you are both, professors. I mean, hopefully you're giving that education in medical schools.
I think so. I think there's so much to learn and cram into medical school curricula, but given the epidemic of obesity and related complications, we really need to prioritize this.
And again, as we mentioned, weight bias, tends to get in the way. 62% of women and 54% of men with overweight or obesity reported hearing an inappropriate comment from their clinician, right? And who's to really blame those clinicians so much? We're not here to blame anybody. We're here to recognize that that's the way society feels. Society says you should just eat less and exercise more, and you should be able to do it. And if you can't do it, you've failed somehow. And I think that's what we're trying to get across, is that when the society feels that way, it's sort of normal for the clinicians in the workspace to feel that way too. But we can't let that get in our way. Because certainly if patients internalize that weight bias, then it makes their disease even harder to treat, because then the patient feels like it's their fault and they're not able to accomplish, what they need to accomplish. So what factors favor effective weight management? In the Action.io study, people with obesity were motivated to lose weight if they were comfortable in discussing weight with healthcare providers, if they were confident that it was easy for them to lose weight, and considered healthcare providers as a source of information. So again, more than just the internet, right? I mean, hopefully the patients feel like we are the source of information, so we should be delivering that. Healthcare providers were more likely to help people with obesity with weight management if they were obesity experts or trained. So here we're going forth and training our colleagues today, felt comfortable discussing weight, registered the diagnosis of obesity in a patient's chart. It's important for us to put it in the chart, and believed that their patients could lose weight. So again, had that sort of success. What strategies exist for us to improve obesity care? So some insights from the Action.io study brought up this 3D approach, and let's talk about that for a second. So the idea was discussion, diagnosis, and direction. Discussing in a non-stigmatizing way. How is your weight affecting your health, and how can I help you with that? Making the diagnosis and putting it in the chart, and then providing the patient direction. Dr. Armandos, is this something you do with your patients?
Yeah, I think it's so important to have meaningful conversations about what it means to have excess or dysfunctional adiposity in your body, how this relates to your health, so that you can come up with a plan with the patient. I think that shared decision-making is so key to try to remove the stigma from a lot of the approaches, unfortunately, that the patient may have experienced in the past.
Dr. Francavilla, how do you help patients overcome that idea that this is my fault and I could just do better?
Yeah, I think that word discussion is really powerful. It should be a two-way street. When people are just told to do something, it often makes them react more negatively, right? And so when we find a little bit about the patient's journey, what they've tried that maybe hasn't worked or didn't work long-term for them in the past, and what their goals are, do they want to be able to walk when they go to Disney World with their grandchildren? Do they want to be able to comfortably sit on an airplane? Do they want to be able to wipe themselves when they go to the bathroom? Are they worried about diabetes? What are their concerns? And how can we as a healthcare professional help them with that? That's when it becomes really more powerful to people. When we just tell them what to do, they tend to get a little more frustrated many times.
Totally true. That shared decision-making, which we'll talk about in a bit, is so important. One last topic that I'd like to hit on is this idea that, we have an issue with making the diagnosis of, putting that diagnosis on the chart because of some of the stigma and bias around the diagnosis. We talked about how to level set that, how to approach patients and actually, get that diagnosis on there. But Dr. Francavilla, can you comment on why it's so hard to get coverage for obesity treatment as a disease, in the United States in particular?
So I think there's lots of reasons why the coverage is problematic, why there's not coverage. The first and foremost being what we've talked about is bias and stigma. So really this lack of acceptance, both medically and politically, that obesity is a disease and that it's treatable. So as a result, it's not required that health insurance plans cover the treatment of obesity. And that could mean anything from the coverage of me just talking to my patient about the treatment.
And billing for it.
Billing for it, right? They are not required to pay for that time I spent with the patient. They don't have to pay for the medications. And so because these are not required benefits, patients often don't have access to nutrition counseling or medications or surgery at various places throughout the country because, again, it really has not truly been accepted as a disease where an insurance company is mandated to cover it.
Right, like other diseases, hypertension. A patient doesn't have to, when they're changing jobs, they don't have to ask the new job, well, do you cover cancer if I get cancer? Do you cover my diabetes if I get diabetes? No, it's known that those are standard benefits on our health insurance. Unfortunately, obesity is carved out, and it's the employer's decision to add it. Thankfully, a lot of our Medicaids across the country are adding it, and we know we have a bill before Congress to try to get Medicare to add it as a standard benefit. And hopefully, with some of these changes, it'll just be recognized as a standard benefit instead of a extra carve out that has to be, added by an employer. It shouldn't be, I feel bad for the employers a little bit that they have to make this decision.
Right. It shouldn't be a decision that anyone is having to make, right? I mean, an employer or an employee shouldn't have to say, is cancer covered, right? Just like we shouldn't have to say, is obesity covered? It should be considered like anything else our patients are struggling with.
Couldn't agree more.
So, Carolyn, why is it so hard to lose weight? Can you tell us?
Yeah, absolutely. One of my favorite things to talk about. And I think this is so important when we are explaining things to patients that they understand this as well. And it helps reduce the bias and stigma and shame around weight. So obesity is very complex. And we know that there's many reasons people struggle with their weight. There's psychological factors, there's socioeconomic factors, neurobehavioral factors, genetic predisposition, other things in the environment that are affecting health and weight. But one of the key elements that we always go back to is this energy intake versus energy expenditure. Unfortunately, our understanding of this in healthcare and how it affects our patients has often been a little misdirected. So what we really need to understand is that when someone tries to lose weight, their body adapts by doing two things. The first is what we call metabolic adaptation. which means that as someone cuts calories, starts losing weight, their metabolic rate goes down. And so they're actually burning less calories than we would expect.
Not fair.
It's really not fair. And that's the language I use with my patients all the time. It's not fair, right? And our patients, or maybe you have seen this yourself, you follow a plan, you follow a diet, a routine, and you're losing a little bit of weight, and then at some point it plateaus, even though you're doing the exact same thing. And maybe after 5 pounds, and maybe after 40 pounds, but at some point, for everyone, usually sooner rather than later, that metabolic adaptation kicks in, and your metabolic rate decreases to adjust for the fact that you're eating less. And then the other thing that happens, the second thing, is appetite adaptation, which means when you're losing weight, when you're cutting calories, whatever your program is, your appetite actually starts to go up to compensate for it. And then your hunger is up and your satiety, your fullness is down. And so people have a hard time sticking with whatever they were doing, not because of willpower, but because of physiology. It's biology. And so explaining this to patients can be really powerful. And then for us to understand this as clinicians helps us take away the stigma and bias and realize it's really not our patient's fault, it's physiology. And then, of course, there's lots of other factors that go into this, right? From socioeconomic drivers, cultural, neurobehavioral, psychosocial. There's so many other factors that are adding in, but it's key to understand that appetite and metabolic adaptation. So, when we are thinking about this, we want to continue to think about lifestyle, meaning sort of diet, exercise, and behavior as our foundation of obesity treatment. But what we see is that diet and exercise alone are not very successful interventions for the majority of people. Studies will show that only about 5 to 10% of people are able to have meaningful weight loss long-term from lifestyle alone. So I like to think of those as the foundation for everyone. We should all be eating healthier. We should all be moving more. But for many people who have obesity, the majority of people, if they want or need significant weight loss, we need to layer other therapies on top of that, like medication, surgeries, procedures, in order to help deal with that metabolic and appetite adaptation.
And on that topic, what do you tell patients as far as lifestyle tips? We talked a lot about lifestyle intervention and things like that. Dr. Finkvilla, what's your go-to? How do you make it easy to be able to be done in 2 minutes, right?
Yeah.
Versus...
I think one thing is normalizing it. Nobody wants to feel like they're in trouble or they have to be on a special diet. And so talking about it, we should all eat more vegetables.
Right.
We should all shoot for a balanced meal as opposed to you are on a diet, right?
Right.
And so I like to, do sort of a plate method where I draw half the plate as vegetables or produce, a quarter of the plate as protein, and then the last, eighths as fat and simple carbohydrates, and talk about what a balanced meal looks like. And then just quickly give the patients a reasonable calorie goal. They don't have to track every single thing, but sort of an estimate. Or sometimes I'll also give them an estimate of a protein goal. I'll often just give around 100 grams for women or 120 for men. You certainly can grams of protein as a goal for the day. Mm-hmm. You can certainly calculate more specific doses, but if you're just trying to get a reasonable, goal for someone to shoot for, those are nice round numbers that work. So those are the quick nutrition tips that I'll give.
How about you, Dr. Almanos?
I tell my patients all the time, I'm shooting for practical and sustainable, not perfection.
Right.
I think for so many people who've lived with obesity for a long time, they've often cycled through a variety of different restrictive style programs where they're accustomed to, I can't eat this, I can't eat between this time and this time. And then when you give them an agent that's really powerful at suppressing appetite and inducing satiety, sometimes they may lean into that in a way that really doesn't support good health outcomes. And again, it's so important to reinforce that this is not about you just losing weight. This is about you improving your overall function and improving your health, to make sure that, as you said, we're focusing in on protein intake, fluid intake, fiber intake, all the things that our body needs. And I kind of tell my patients, we're not shooting for restriction. I'm not going to tell you that this is a bad food or not to do it. We're going to find the right balance and frequency and amount that's right for your body and where you want your body to be. And I think that can be really helpful for patients who are expecting a very restrictive approach, because in my mind, restrictive is not sustainable. And I think it can be game-changing to help people look at what do I need for my body to feel healthy rather than what do I enjoy that I can't do anymore.
Exactly. And I have my 5 Ps because they fit on one hand and they all start with P. So that's how I remember it. Planned portions. It's actually 2 Ps, but I put it in one. Planned portions. Plan your portions, right? Don't skip meals. Plants and protein, as you mentioned, protein and plants, because plants have nutrition and fiber, right? Power for doing some sort of strength-based, activity. Pillow for sleeping well, right? Because sleeping well is very important. We didn't talk about that a lot, but that also aids in our metabolism and helps us to do better. And then pause, which is really about stress reduction, pausing, maybe meditating if that's something that the patient wants to do, or yoga or something, that is mindful in terms of reducing stress, because we know stress also can lead to worsening weight outcomes. So those are my 5 Ps. You can take them or leave them, but I like to keep things simple, as you mentioned.
Absolutely. What kind of physical activity do you recommend to your patients? I know that you're an enthusiast. What do you tell people?
Well, Dr. Francavilla is really the enthusiast. So I take everything comes from her, she is my inspiration. But I do encourage some strength training, especially for people, I think over 40 in particular. I mean, everybody, but especially as we get older, working on, building our strength is important, in addition to the normal sort of, day-to-day increase in activity.
I think the easiest thing for a primary care physician to remember is the physical guidelines for healthy Americans, which is our goal for everyone, once again, is 150 minutes a week of physical activity with at least 2 days of full body resistance training. And so however you can gently get your patients to there, I have patients I've had start with 1 minute of movement a day. So if there's someone who are very deconditioned, very uncomfortable with the idea of exercise, meet them where they're at. But all of us should be shooting one day to be at 150 minutes a week with 2 days of resistance training.
Yeah, I think that's such a great point, that change comes from change, and helping people to take that first step is so powerful.
Well, those are such important topics, right, for us to get across. And how do you help patients understand that obesity is not their fault, and that this lifestyle alone isn't going to be the solution to treatment? Dr. Armandos, how do you attack that?
I think it's so important to educate our patients and our colleagues about kind of the complex physiology and other factors that go into obesity, but also to talk about the neurohormonal changes that happen when people live with obesity, that you can't just put the toothpaste back in the tube. Having somebody achieve a negative energy balance will not maintain them in a weight-reduced state indefinitely, and that there are multiple physiologic factors, like Dr. Francavilla just talked through, that will cause weight recurrence. And I think it's so important for patients to understand that this is not about willpower, and that there are other factors that we need to address in an evidence-based way for better health.
It's your biology, not your behavior alone, right? And it's so hard to fight back against biology. So recognizing that obesity is a stigmatized disease, let's talk a little bit about how to discuss weight with our patients. So clinicians should recognize that weight's a sensitive topic and approach it as such. So patients do not object to discussing weight per se, but how you approach it and how you discuss it is important. I like to say, I'm concerned about how your weight may be affecting your health. Is that something we can discuss today? And especially if they're there for a condition that might be related to weight, such as sleep apnea or other conditions that might come up that have a direct relationship. Probably not the best time to bring it up when they're there with the flu or some sort of acute, illness that isn't related to their obesity. And so again, making sure that you don't lecture patients, as you mentioned, right? Not asking patients if they know if weight loss is helpful, because of course, most people, as we mentioned, have tried 6 or 7 times themselves and are more experts than us. And not telling patients to change their diet or physical activity without knowing about the patient's current behaviors, because a lot of people assume that patients with obesity are not eating healthy. And in fact, they might be eating healthier than me, right? And a lot of my patients have healthier behaviors on a regular basis than I do. So I'm not assuming that is key. And using these 5 A's, right? Asking permission. Is now a good time to discuss your weight? Assess their story. Get a good history, as you mentioned. Advise on management, the pillars of obesity treatment, nutrition therapy, psychological therapy, exercise, medications, surgery, as you mentioned. Agree on goals and assist with drivers and barriers. So weight counseling starts with that asking for permission, right? I'm concerned about how this may affect your health. And if a patient says, I'm ready to talk about it today, right? How do we move forward with that, right? What do we say? We say, what are your concerns? As you mentioned, Dr. Francavilla, like having that interaction, right? But if they say, no, I'm not ready, I think we should also respect that, right? And leave that door open to discuss it in the future and acknowledge people's, concerns, know that you're there to support them just like we would with any other chronic disease. So Dr. Armandos, please give us some examples of how you might do that too. I just, shared some of mine, but how do you do that?
when people come to an obesity medicine clinic at an academic center, they kind of know that they've been referred there or they're coming to talk about their weight. So the surprise isn't there. It's not that someone's coming for a blood pressure medication refill and I'm going to sideswipe them with a weight conversation.
Right,
so
harder.
When people come in and I first meet them, I'll say, people come and see us for a variety of different reasons. How can I help you best? Or what do you hope to get out of your relationship with us as a clinic? And I think it's so important to help people understand that we're there to support them and to identify their goals, and that our goal is not just to reduce that number on the scale. So we work on relationship building. And to touch on something you mentioned before about with the trainees, it's so important when you are educating young clinicians to have kind of stigma-reduced conversations about weight and not to make assumptions. When somebody comes in who is living with obesity, to ask them, hey, have you ever thought about losing weight? Is really one of the most damaging things you can do for developing a rapport.
Right. And Dr. Francavilla, you're, more in primary care, so you might have that episode where you might feel like this is really a weight-related issue. How can I bring it up?
Yeah, so I like to tie it to whatever the condition is. So, for example, if I have someone come in and they are having an asthma exacerbation, I'm going to treat their asthma exacerbation, or maybe it's just not well controlled, with the appropriate medications. And then I might say something like, Mr. Smith, one other thing that I think might be impacting your asthma is your weight. What do you think about your weight? I've always used that question. What do you think about your weight? And I have found that really in my clinic, 100% of patients have responded well to that. It's just such an open-ended question that they can tell you their frustrations, their struggles, what they're interested in a very open-ended way. So that's the question that I'll use is, what do you think about your weight? And then I try to tie it again to a reason why it should matter to me as their doctor, as opposed to, some other reason. I don't care what they look like in a swimsuit, but I do want them to be on less medications and live longer and live better. And so I think being clear on that with patients, like, I'm just here to help with your health.
Huge, huge. Let's discuss now how much weight loss is needed to obtain different health goals. We talked about the fact that it's not just about a number on the scale, right? And in fact, we know also that really this is not something that we are trying to get to a normal BMI. Patients come in all the time and they say, Dr. Francavilla, I think I should weigh this much. And if you ask them why they think that, it's because that's a normal BMI. And tell us more about that.
Absolutely. I hear the same thing from my patients. They've looked at a chart in their doctor's office or online and they say, I need to weigh this. This is what the chart says. And I have to, step them back and figure out what's a goal that makes sense for them. And so for some people, getting to a normal BMI is probably not physiologically realistic. And most of the time, it's just unnecessary. And as we discussed earlier, BMI is not really the definition of health or even obesity. So let's look at, what some of the correlated complications are with obesity. So these go up as BMI goes up in most cases, but we are looking at factors like dyslipidemia, high cholesterol, arthritis, back pain, type 2 diabetes, gallbladder disease, asthma, which I think sometimes gets forgotten, coronary artery disease, stroke, Alzheimer's. So these are all things that are related. And so what treatment intervention do we really need to see improvement or a decreased risk in those complications from obesity? So when we look at high blood pressure and hyperglycemia, we see that even a 5% weight loss is going to have an impact and improve health for the patient. When we look at other conditions like preventing type 2 diabetes, NAFLD, or dyslipidemia, we see that a 5 to 10% weight loss is often going to resolve or significantly reduce those risks. When we're looking at cardiovascular disease or NASH, we see that a 10 to 15% weight loss is often going to resolve those conditions. And then when we actually look at remission for type 2 diabetes, making type 2 diabetes go away, improved cardiovascular mortality, and heart failure, we see that around a 15% weight loss often will have a huge impact. So I think that this is very important when setting goals for our patients is what are their actual risk factors? What percentage of weight loss would improve their individual health condition? And then, how are we likely to get there? But again, very important to realize you don't have to get to a normal BMI to improve health. And then this data I find very interesting because it talks about something that I think we miss a lot in this discussion, which is like, how do people feel? What is their function? And so this comes from the STEP trials on semaglutide. And what it's looking at is two different scoring tools on improvement in physical functioning for the patient. So they had two different scoring tools they used for this. And there was clinically significant improvement in function when people were on semaglutide and losing weight. And so very important to realize that it's not always just about, improving cholesterol or improving asthma, but how do people feel? And that's what will often make our patients continue to stay engaged and continue with the recommendations we give them is when they're feeling better.
You probably hear that a lot, Jamie, right? People come in and they're like, I feel so much better.
Absolutely. And I think helping them to align their goals around weight reduction is so important. So many people think they need to lose 100 pounds or more because they've been told by another clinician that this is what you need in order to be healthy. And that's really not true. And so I love the way in which you presented the data because it can really help us to guide more meaningful discussions with our patients.
So true. And how can we help patients set reasonable expectations for weight loss with various interventions is the next step, right? Marrying that sort of like goal of the patient. I need to get 20% weight loss because I need to have a kidney transplant, right? That's very serious, if I need to lose 20% of my weight to get that procedure. How do you level set with the patient that maybe this treatment or that treatment is going to be the best treatment to get them there?
Yeah, I think there's so many tools that we can use to assess where they're at from an obesity perspective and how that's informing their health. I think it's so important to work out from a diagnostic perspective, where are we at? And I think we can use a variety of different tools, such as the Edmonton Obesity scale that we talked about earlier. Plus, we can also talk with the patient about what are your goals. Like you said before, it may be that they want to be able to play with their grandkids, or they may need a specific procedure like a knee replacement, so we can work towards those. We talked about how foundational lifestyle modification is. These are health behaviors that are going to improve, hopefully, quality of life and health overall, but they may not help people to achieve the magnitude of weight loss that they want or need. And so working out, are you able to achieve your treatment goals with that, or do we need advanced therapies? And so we have a variety of different pharmacotherapies that we're going to talk about. And we also have bariatric surgery, and I tell patients all the time, we live in a world of and, not or. So we don't need to choose right now, and we can start something and change. Because obesity is a chronic and complex disease, we're likely going to need to do a variety of different treatments over the life course. And so working out which is right for this chapter in their life and their health can be so powerful and meaningful as part of a chronic disease management journey. And I think we really need to contextualize that. I think it's great that so many societies have been able to put forth these paradigm shifts on obesity as a chronic disease and helping clinicians to choose which treatments are right for that person in the room based on the magnitude of weight change that's needed, in addition to where they're at from a health perspective and evaluating the current evidence. And it almost feels like every day we're seeing a new study in a journal or getting an email about a new FDA approval, let's say, for a different indication for a treatment. And so it's really exciting to have all these options. But we need to also acknowledge the autonomy of patients in this process too, right? And work out, is this something that you want? Have you found kind of a shift in terms of what patients are coming in asking for or expecting? Have you found any differences between, for example, bariatric surgery enthusiasm amongst your patients versus medications these days?
Yeah, I think, most people, because they know so much more about medication today, and our medications are getting so much better. Our treatments are getting more effective, getting patients closer to that 20%, for example, treatment, that I think that's something that's very helpful, for patients to, they understand that now, so they kind of want to try that medication at least first. But it's important for us, I think, to get across to them that if that's not effective for them, it's not because they failed, right? It's not their fault. The treatment just didn't work out for them, and there's other treatment.
I think that's so important. How do you help patients to understand that it's not them that's failing, it maybe the treatment is not right for them? How do you have those discussions?
I think that language is beautiful and perfect, right? Like, it's not that you failed it, although we may have to put that on your insurance form, right? Like, that may be the language they want to hear. But that it just didn't work for you. And I think that makes sense to people because they've probably had that experience with something else before, whether it was an acne medicine they used that didn't work for them, or whether they had an antibiotic that they used at some point in their life that didn't work for them, right? And I think that language is the right way to say it. It just didn't work for you. We have other tools.
Yeah, you made a joke about kind of payers and the way in which treatment things can be decided or care algorithms, and still so many of these things are BMI based. And, for example, with anti-obesity medication therapies, we're talking BMI greater than 30 or 27 or greater with a complication related to weight, or for bariatric surgery, 40 or greater, or 35 with a complication. And so many patients will come in and go, why are you talking about surgery? I don't have that kind of weight that I need to lose, and helping patients to understand that these are all effective tools, but also that they get to choose which journey they go on with us, right? When we look at the magnitude of weight change that we can see with a variety of interventions, we've talked about lifestyle being foundational, but typically we see somewhere, depending on the magnitude of change, the calorie restriction, or the energy expenditure we have, somewhere between maybe 1 to 10%. But it's really challenging for the variety of physiologic reasons that Dr. Francavilla discussed to maintain that weight reduction. We're fortunate to have kind of a growing selection of obesity medications that are helpful. The older generation, we're talking kind of phentermine, topiramate, bupropion, naltrexone. Really what we're seeing there is kind of a 5 to maybe 9 or 10% weight reduction with that. With newer next generation therapies, we have maybe 15 to 21% with regards to semaglutide and tirzepatide. And this is really the new generation of therapies that really have shown not just to decrease body weight, but also to improve overall cardio-kidney metabolic health. And we have bariatric surgery. Until recently, we really didn't have treatments that consistently help people to achieve that magnitude of weight loss you talked about, Dr. Francavilla, about 15% or greater to induce disease remission, where now we have medical therapies. So the question is, how do we help people to choose, and how do we guide those discussions? It can be really challenging. One way to talk about it is with regards to the risks and benefits, and we have a nice practice aid that can help our clinicians to decide which treatment may be best for them and which salient points to bring up with their patients with regards to magnitude of weight change and potential adverse effects of these therapies. I think it's also important to talk about the time it takes to lose weight on these treatments. I saw an article, I think, earlier last year with regards to treatment persistence with newer medications. And I was shocked to see that it was like a 40% discontinuation rate for new anti-obesity medication therapies within the first 12 weeks or so. Do you see much medication discontinuation, or why do you think that happens?
Well, we don't really see that. I mean, and I guess, I don't really see that personally in my practice. So I was a little bit the same with you, right? Struck by that, because I think, we do a lot of education with patients as to the importance of medication. I like what you said earlier that, when you said they might need that to do better, right? Nobody wants to take medication or wants surgery, but we might need it if we want to accomplish our goal. And I think differentiating that want versus need is where it's having that discussion with patients is important, and sometimes that's not happening in all instances, I think.
Yeah, I think it's so important to include these in conversations, but also with regards to helping people to set a timeline, right? So when we look at data from clinical trials, with newer agents, we're talking 68 weeks, 72 weeks, and some of the other trials are even longer. And when patients are discontinuing medications, 12 weeks in, we may not be seeing maximal benefits of treatment. Beyond that, we also see a lot of variability with regards to treatment, whether someone is doing lifestyle or dietary intervention, pharmacotherapy, or bariatric surgery. We see what's like a normal distribution of the amount of weight they lose. How do you guide your conversations, Dr. Francavilla, with patients with regards to here's what to expect? Because everyone looks at kind of the mean or average weight loss, and they expect, or they know someone who's lost X number of pounds. How do you guide that discussion?
And I often see families, couples, parents, children, so they may be living with someone else who's taking the medication. And so I think explaining that there is an individual response and then directing back to the patient's goals. We've kind of long considered a 10% weight loss to be like a good weight loss. In the studies, 5% is the outcome, right? So if it's a 5% weight loss, we consider it a successful anti-obesity medication. So I think most people are not willing to take a medication long-term for a 5% weight loss, but there may be a medical reason why that is a good reason, right? They may have had enough benefit from 5%. But I think celebrating the wins, if someone's had a 7 to 10% weight loss on the medication, they feel good, their blood work looks good, they're seeing the health improvements, we have to celebrate their success, right? And so, yeah, that's great that someone else had a 25% weight loss, but you had a 10% weight loss. You've lost, 25 pounds, you've lost 40 pounds. How has that impacted your health and redirecting it to their goals, their health needs?
Yeah. Older studies would suggest that patients might be disappointed by only that 5% weight loss, let's say. So how do you guide that discussion then?
Yeah, I think it's really individual, right? So, okay, you had a 5% weight loss. It's also important to realize weight loss could be different things. I just have a very active patient population. They work out, they're CrossFitters, they run, they exercise. And so sometimes they may have only had a 5% weight loss, but we look at their body composition and they had 6 or 7% body fat that they lost. They actually put on muscle while they were losing weight. So, we can't get caught up too much in numbers. And then looking at the health outcomes. How does the person feel? Do they have better energy? Do they feel more comfortable? Do they have less reflux? Is their blood pressure better? What does their lipid panel look like? All those things can be encouraging reasons that the medication is working, even if, the scale hasn't changed dramatically.
So important, right? And also, as you mentioned, people want it fast. Right? I mean, that's the thing. What do you tell people, Dr. Armando's, as far as because they come in and they're like, oh, I only lost 10 pounds this month. I was like, that's a lot, right? How do you level set that? Because everybody thinks it should happen tomorrow.
Exactly. I think, we need to kind of level set with patients with regards to what creates that magnitude of weight change. And unfortunately, the amount of malnutrition that you need to create to do that may not be good for the health outcomes. It may be kind of problematic for maintaining muscle mass, especially if you're not consuming adequate protein or being physically active, or it may have detrimental effects on bone health, for example. So I think it's so important to level set with patients about our goal is not just simply to reduce the number on the scale, but to improve function and quality of life. And this is all part of that.
Another topic that we should address is that not only are there side effects from medication, but there are side effects of weight loss, right? So sometimes we have hair loss and we can have increase in gallbladder symptoms. So making sure we educate our patients about some of those side effects of weight loss versus the side effect of the medication and how to differentiate the two. Any specific tips you might give patients?
Yeah, so we will sometimes see, like you said, hair loss, and letting patients know that's usually a temporary side effect from the weight loss. It may not be directly from whichever medication, because I've heard all of them on our list from the slides blamed. But usually it's really just more directly related to weight loss. And really always balancing that risk-benefit with patients for any side effects. So like you mentioned, if someone's having, vomiting every time they eat, that's probably not a very healthy way to go through your life. But if you've had, some thinning of your hair, but your life is overall better, your health is better, that may be an acceptable trade-off depending on the person.
Exactly.
I think there are a lot of different things we talk about in the clinic with our patients, but just making sure that we have an open dialogue. And if you're not feeling well with this journey, we want to know about it and we want to see you back if you're not feeling well.
We want to try to help make it better.
Exactly.
Yeah. So important. And next, what challenges are you seeing among patients with long-term use? As you mentioned with that study, right? Patients are, at least the studies are telling us there might be something else going on in there with as far as access and insurance coverage. But, when your patient asks you, Dr. Armando's, when they say, do I need to take this drug forever for the rest of my life? Tell us about that.
These can be some of the challenging conversations we have with our patients because they may come in with about 5 or 10 medications already on their medication profile. And they're like, I just don't want to start another one if I'm going to have to stay on it for life. I think the way we frame it, and the way I start the conversation, is let's not drive beyond the headlights. Let's focus in on what your health goals are, and let's work out on what it takes to get you there, and then what we need to stay there once we're there. And as part of that, depending on what their health history is, they may have additional medications which we can reduce, such as diabetes medications or blood pressure medications that they may need less of as their weight decreases. So there's lots of different ways in which we can approach conversations that may seem challenging at first. I think some of the challenge comes around what happens when people stop these medications. I feel like there were a lot of stories in the news last year about medication discontinuation and weight recurrence, and that means that these medicines don't work. I would kind of push back the other way. When you look at data, for example, from the Step 1 extension trial or the SURMOUNT-4 trial, which looked at semaglutide and tirzepatide respectively, what it shows is that with medication treatment, we see very nice reductions in body weight. And with medication cessation, we see over the next year about 2/3 weight recurrence in terms of what they've lost. To me, that points to these medications being effective when you take them, and that in the absence of these medications, we have recurrence of what is a chronic disease or condition.
Which is true of most medications or most diseases.
I mean,
we accept it for other things.
If this was a blood pressure or a lipid conversation, we wouldn't even be having the conversation. It would be accepted. Yeah. But I think it just goes to show, as you said before, the systemic weight bias that we have, even amongst healthcare providers, unfortunately, about obesity as a chronic disease. Dr. Frankville, how do you approach conversations about kind of chronic disease management with patients if they're worried about weight recurrence with stopping these treatments?
My standard phrase that I've said for many years is, whatever you do to lose weight, you have to keep doing. And so this often is feeling true to my patients because we've explored what have they done in the past. Well, I did the keto diet, but I couldn't stick with it. Well, if you did the keto diet forever, it may have worked forever, right? But people have a hard time sticking to some of these interventions. I've had people who worked out 3 hours a day and they lost weight, but they couldn't work out 3 hours a day for the rest of their life for lots of different reasons. And so it often seems true to patients. It makes sense when we sort of explain it that way. But I think the key thing is these medications work, and when we stop them, then they stop working, just like most medicines. So I think being upfront with that conversation, and I liked your analogy of, what did you say, don't put the car before the headlights. We don't know, right? Everyone's response is going to be individual. There may be a reason you can't take the medicine, and we'll deal with that problem when it happens, right? We have other medicines, we have surgery, we have other tools. You may be the person who doesn't need to take it forever, but we should go in expecting that whatever you do that's working, you're probably going to have to keep doing.
Absolutely. And when you look at the magnitude of weight change, we see 15 to 20% with pharmacotherapy now, with more advanced therapies, and with bariatric surgery, say 20 to 35%. The kind of lifestyle interventions that people would need to do in order to achieve that within 1 year and maintain it are probably not sustainable for the average person long term. And I think helping people to understand that we can use advanced therapies, be it pharmacotherapy or surgery, as an appliance to help get the job done. I tell people all the time, it's like what we're doing. Exactly. It's like having a washing machine. It doesn't pick the clothes up off the floor. It doesn't fold it up or put it away, but it's something that helps us to get the job done. Similarly, when you have a washing machine, you could do with a dryer. And so I use this as an analogy when we talk about pharmacotherapy and bariatric surgery, because they're doing similar jobs and they're helping us to get the task done, but they're different types of treatments and they're different types of appliances. Because what we do know is that when we use therapies consistently, as you said, they work. And we have data now. We have 3-year data from tirzepatide looking at those in the SURMOUNT study who have a history of prediabetes, showing persistent reductions in body weight and reductions in kind of progression to type 2 diabetes at that 3-year mark. So we know that these medications work long-term. We also have 4-year data from the SELECT trial showing that people maintain their weight loss when they're on treatment. And so I think it should be reassuring for patients that these medications do work when we take them, but having the conversations about what chronic disease management looks like, I think is kind of nuanced and different for everyone.
So tell me, Dr. Alamandos and Dr. Francavilla, many people have to stop medication for various reasons, some of which can be adverse side effects. How do you help manage side effects for patients?
The first step, I think, is to let patients know what common side effects from the medication might be. So in the case of our GLP-1 receptor agonists, nausea is a common one. Patients can often have constipation, sometimes diarrhea, reflux. So letting them know, number one, that those are not uncommon, and then giving them some tools ahead of time to reduce that. In the case of nausea, eating small, frequent, balanced meals can be a simple tip that help people be more successful on the medication and have less of those GI side effects. For constipation, staying hydrated. Sometimes people will drink less water on those medications because they're not as thirsty when they're not as hungry. And so making sure that they're drinking drinking water frequently. And then fiber, of course, any primary care physician.
Fiber is your friend.
Already knows that. So the things you would normally do to treat constipation are still going to be the same things you're going to use to treat constipation on these medications. Same things with diarrhea. And then I think it's important to recognize, at least for my patients, that just because one medication gave you that side effect, if say semaglutide gave you a side effect, tirzepatide might not, and vice versa. And so if the patient does want to try the medication, they may do fine with a similar med that's different in terms of that side effect profile.
And there are a host of our other older medications, too, that have very different side effects. Dr. Armando's anything to add to that?
I just wanted to kind of highlight kind of what Dr. Francavilla said about making sure that patients understand the mechanism of action of these medications and to help them to understand how to modify both their nutritional intake, but also over-the-counter things, including fiber or other laxatives or treatments that can help to undo some of the side effects. But with regards to medication side effects, we also want to talk about medication dose. And I think for so many clinicians, they may feel that they're going to see the best response for their patients at the highest available dose. And the goal is not to get to the highest dose. The goal is to find the right dose for the patient, and making sure that patients are seen back regularly, that they're asked, how are you doing with this? What changes are we seeing beyond just the body weight, but with regards to your bowel habit or how you're feeling, your strength, your function, your energy levels, making sure they're on the right dose for them, decreasing the dose if they're not meeting their nutritional needs, or if they're having any adverse side effects, can often be helpful to help people remain on something that's ultimately helping them, albeit maybe slowly, to get to their goal, but maybe also providing them additional health benefits beyond weight reduction.
Yes, and so important, right? Because I think patients have been looking for solutions for so long. And when they're looking for solutions for so long, they tend to tolerate some side effects that maybe they shouldn't be tolerating, long term, meaning, if they're having massive diarrhea, multiple times a day and at risk for malnutrition or dehydration, from that, it's important to ask these questions because they might not voluntarily say it because they're afraid you're going to take them off of it and then they're not going to have that treatment available. And it's actually working, right, to reduce their weight.
Absolutely. People can really normalize what we would consider to be some abnormal type side effects or symptoms. And I tell trainees this all the time. You need to specifically ask because patients will be afraid that you might take the medication away first, or they may have heard on social media from a friend, this is normal. It's normal to throw up after you eat. It's not. And we need to denormalize that for them to help them understand that we may need to adjust the medication dose or some of the lifestyle behaviors that are going into that. And I think taking a good dietary history and focusing on lifestyle can be really important as part of that too.
So true. And Dr. Francavilla, what do you tell patients who want to discontinue, who say, I've reached my goal, now I should stop, right? Like what? Because I feel like there's a growing movement out there socially that suggests that people should stop when they get to their goal. And part of that's, for different reasons. But tell us what you might say.
I think, again, the first step is in the beginning, letting them know probably you're going to want to stay on this long term, but that question will come up for lots of reasons. Maybe the cost of the medication has gone up. Maybe they feel like they don't need it anymore. Whatever that may be, or they just kind of are stuck in this idea that once you've lost it, you'll be able to keep it off. And so I would always gently encourage them that they probably are going to need to stay off of it. But if they really want to try going off of it, then we'll come up with a plan and then have frequent follow-up with me to check in so that if they are regaining weight, we can restart the medication or switch to a different intervention, whether it's a different medication or considering surgery, and making sure they know it's not their fault. So I really like to be clear on that. When they do stop the medication, if you regain weight, it's not your fault. It's just that biology. And please come back to me right away. Let's get an appointment on the books to check in 4 or 6 weeks, see how you're doing without the medication, and see what this looks like long term. We've all had this happen, I'm sure, right? I have in primary care patients who want to try off their antidepressants, who want to see, maybe their blood pressure's been looking really, really good and they started walking. Do they still need the medicine? And sometimes they do, and sometimes they don't.
But making sure, right, that they come back, I think that's key. Because I don't know about you, Jamie, but I've had so many patients that don't come back, unfortunately, until 20, 30, 40 pounds, of regain because of that bias. This is your research, like the bias and stigma. Like, how do we really, get those patients back so that they don't end up like that?
I think this is such an important topic because obesity is a chronic disease and patients will be managing their obesity for their lifetime. This is not going away. And so I have a lot of frank conversations with patients who are considering discontinuing or de-escalating therapy. We start off with, tell me why you're interested in decreasing or coming off of this. Because there are so many factors now. Cost, access, all of these things beyond this is just one more treatment I don't want to add to my list of things to do. As Dr. Francavilla talked about, setting goals, seeing them back frequently, adjusting the medication dose. But I'll kind of flip it a little bit as well. Conversations around chronic disease management. We know that many medical therapies now that we use for obesity do so much more than decrease body weight. The question is, what other things are we foregoing when we stop this? As an endocrinologist, I see many people with type 2 diabetes. So the question is, even independent of weight recurrence, what might happen with their blood glucose or their cardiometabolic risk? We have data, for example, on incretin-based therapies decreasing cardiovascular risk, decreasing progression of chronic kidney disease, treating sleep apnea, potentially treating metabolic-associated steatotic liver disease and other factors. So what are we foregoing if we discontinue therapies? And so we have conversations long-term with our patients about what are you hoping to achieve for your health and how can we do this through whichever treatment you would like to do.
Right, and making sure they're on the lowest dose that could maintain them. That is certainly another strategy. If a patient does have to go off because of cost, Dr. Francavilla, have you had people go on other medications?
Yeah, certainly. I have had some patients who have had success maintaining with diligent lifestyle. So they are sticking with a nutrition plan. They're moving very frequently, usually close to an hour a day. We have data from the National Weight Control Registry, which I always love to talk about, that says, that hour a day of movement is often needed for weight maintenance. And then switching to an older generic medication, sometimes a combination of, say, phentermine and metformin, phentermine and topiramate, one of our other options that maybe was not as powerful as their GLP-1, but is allowing them to maintain. But I think to your point, the metformin and phentermine may not have the same benefit to fatty liver disease, sleep apnea. We just don't know, right? If they're going to have that benefit without the medication that's been studied.
So on that note, Dr. Almondos, what gaps in research? What do we need to look at moving forward to try to figure this out?
I think there's so many things we don't fully understand or know. As we talked about before, there's a lot of variability in terms of response. How do we best address people who are not responding from a weight perspective or from a cardiometabolic health perspective the way that we're hoping that they will? And so which treatments are best for people who may not respond to another treatment? How do we add in or use sequential therapies? When do we switch from medical therapies to surgery? I think there's so many things. And what are the best treatments after bariatric surgery? So
we have a lot of research, right? A lot of time ahead of us to get some of this research done because it's much needed in this field. We also get lots of questions, switching gears a little bit, about compounded incretin peptides. So what should we tell our patients? I think, one of the key things that I always want to get across to other clinicians is that, these compounded incretins are not FDA approved. There is no generic for semaglutide. There's no generic for tirzepatide. So it's not like a compounding facility can just purchase truly generic FDA approved drugs to put into the compounds, right? So, and then that compounding process itself is not overseen either by the FDA directly or approved by the FDA. There's certainly lots of good overseeing of certain compounding, from a good manufacturing practice and, that people are doing it in a clean, environment, et cetera. But this is not an FDA approved treatment. And because of that, clinicians who prescribe compounded incretin peptides are assuming the responsibility of not only the treatment, but the content, the quality, and the safety of a medication that really hasn't been studied for safety and efficacy. So I tell other clinicians and patients sometimes, well, you could do it and it might work, but it might also be harmful. And that's not usually what we usually don't use words like might, when we talk about medications. I mean, typically. So, Dr. Armandos, what would you add to that?
I really wish we had better access to evidence-based care for our patients. I mean, you can't open your social media or a newspaper, if anyone reads newspapers still, without seeing challenges around access to treatments that are helpful for weight and cardiometabolic health. And so I can see why somebody might feel that they need to go down a route that's maybe not evidence-based, but talking with the patient, what's your goal with this? And many of them will say, my goal is to have better health. And I said, well, let's work out an evidence-based way to get this done. And let's work out what it is we need to do to get you there. And I think having conversations, as Dr. Francavilla kind of shared earlier, about non-incretin-based therapies that may be more accessible to that patient, talking about bariatric surgery, which is still one of my favorite tools for treating obesity because of the strong evidence base, particularly for people living with severe class 3 obesity. And so I think there are a lot of different options we can do that are evidence-based that can help patients to achieve their goals. But having that discussion is really the first step.
And surgery has a lot of data on safety and efficacy, right? Which we have, unfortunately, no clear data on the compounded products for safety or efficacy at this moment. And you can't assume that the safety or efficacy is the same as the actual FDA-approved medication. And I think, that's where it gets a little tricky. Dr. Francavilla, anything?
I mean, I think you both summed it up really well. And what I'll talk about with my patients is, the reason I help people with their weight is to improve their health. And that I personally have more concern that using an unregulated compound version could cause more health harm than benefit. And so let's look into what some other options that might make sense for their health would be.
And as physicians, I think in particular, we have to remember that, we took an oath to first do no harm, as part of our medical school training. And so, again, recognizing as well that the FDA, the ADA, and other organizations have expressed concern about unapproved GLP-1 drugs used for weight management and obesity treatment. The Obesity Society, the Obesity Medicine Association, and the Obesity Action Coalition have issued a joint statement recommending that patients do not use compounded semaglutide and tirzepatide. And so again, if you're doing this and recommending it, you're going against a lot of different large professional recommendations, which could be challenging if someone has an adverse event to support that as far as long-term outcome. It also should be recognized that sublingual and other forms of these types of treatments are just not actual drugs, right? We don't actually have those as forms of therapy.
Yeah, I don't know about you, but my social media is just full of ads for things that are not even FDA approved yet, that are still under phase 2 and phase 3 clinical trials, and directly being marketed to patients for treating their obesity.
Which is so unfortunate, and I think why we're here, to educate on this topic so that hopefully we can all understand the potential, risk and downsides of something, such as this. It's also important to note that agents that are labeled for research purposes only are not suitable for human use. They're not designed for humans, yet they're, again, being sold, out there in the market to humans, unfortunately. So we've covered a lot of important questions about obesity management today. So let's summarize the key points if we could. So our key takeaways that we hope you have learned today is that primary care clinicians can play an important role in the diagnosis and treatment of clinical obesity, also preclinical obesity, right? So not just clinical obesity, but the whole spectrum of obesity care. And how can we really help that patient in that shared decision-making fashion to reach their treatment goals? Weight loss activates multiple physiologic changes in the human body, as Dr. Francavilla, educated us on, most of which are not under volitional control. This is not your fault. This is not the patient's fault for their disease state. We really want to get that across. And that increases the risk of weight regain if a patient internalizes that stigma and bias. So trying to get rid of that and make this a more comprehensive chronic disease treatment is our goal. And weight is a sensitive topic, so ask permission before discussing it. More research is needed to optimize obesity therapies and treatment regimens after weight loss goals are achieved. We really don't know the future, and we can't predict the future. We don't want to get ahead of our headlights. I like that. I'm gonna use Dr. Armandos' this phrase. And we don't know the future. We can't predict the future. We don't have a crystal ball yet. So again, recognizing that this is a chronic disease for long-term treatment. Weight loss of 5 to 10% improves metabolic endpoints. 10 to 15% induces remission of certain conditions. So matching that treatment goal of the patient, to that treatment efficacy is what's important, and recognizing that lifestyle alone is rarely enough to get patients into those treatment categories successfully, especially when we're looking at long-term maintenance. FDA-approved GIP, GLP-1 receptor agonists, and GLP-1 receptor agonists are the most effective anti-obesity medications we have today and may induce remission of other obesity-related illnesses. That concludes our discussion for today. I'd like to thank Dr. Almandos and Dr. Francavilla for their great insights and stimulating conversation.
Thank you, Dr. Fitch and Dr. Francavilla. It's been a pleasure.
Thank you as well, Dr. Fitch and Dr. Almandos. Really loved our discussion.
I hope you've found our discussion helpful in helping you formulate new strategies for engaging in shared decision-making conversations with your patients with obesity. Don't forget to download the slides and use the accompanying practice aids in your practice. And I hope you feel more confident about implementing effective obesity management strategies in your practice. Thank you very much for tuning in.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/ZCB860.